Now, sir, I'll hand over to Dr. Narvekar, sir, now.
Yes. Good afternoon.
Good afternoon, sir.
Yeah, who's that? Can you hear me?
Yes, yes.
Avinash.
Yes, Avinash. And who else is there?
Our panelists are Dr. Ashwini, sir, Dr. Hetal Chiniwala, sir, and Dr. Avinash, sir.
Hetal is there. Hetal, hello.
Yeah, I'm here, sir. I'm here.
And Ashwin, hello.
Yes, sir. Yeah, I'm there.
Okay. So basically, as you can see, I am in the superior portal. Okay. This is my posterior portal.
Yes.
And there is a significant Hill Sachs lesion, which is more of a deep and a medial Hill Sachs, which is not very good news. And what we've done is we've put in a double loaded anchor. What I do is I then take a separate sort of an incision, which is on the little bit more posterior lateral, and I use my arthro pierce in order to take them out. This particular cannula is in the extracapsular. Okay, so I can take stitches the way I want.
Yeah.
Can we see the extra TV view, sir? We are not able to see your incision.
Outside view. Outside view.
Outside view.
For the port.
So now what happens is I can then, you can see this.
Yes.
So that is how with a single anchor, बाहर का चालू है?
1 minute sir, कैमरा शिफ्ट कर रहा है.
हाँ तो क्या करूँ?
Can you zoom it a bit?
एक मिनट. On. So this Hill Sachs is significant. It is deep and it's fairly medial. So this is the articular surface. The anchor is just above that. From one anchor, I have already taken two of the sutures out. I am taking the third suture out, which is going through the tendon of the infra spinatus. Should I continue or wait? हो गया? चालू?
Yeah. He needs to, I think, change the angle of the camera.
Angle of the camera?
Yes sir, just a minute sir.
From your right shoulder, if it comes, it will be easier to see.
मेरा right shoulder का ऊपर से ले लो. So this way I am going to pull this out. Remember that when you are pulling these out, one sec. The threads out, all the people who are new to shoulder arthroscopy, suture management is probably the most important part of this. You should know now, once you have a loop here, which thread to pull. If I pull the wrong thread, like the one which I am pulling just now, I will discharge the anchor. Okay, so I have got to pull this thread. You see that? So whenever you are pulling threads, don't allow your assistant to pull threads. You should pull threads yourself, the sutures, so that looking at the anchor, you should know which movement of the thread is happening. Now when I look at the anchor, I know that the thread which is coming out is not going to discharge the anchor. Please let me know if I am clear or...
yeah, absolutely, sir.
Okay,
absolutely clear. Very relevant and important point.
So we have 3 and now this is the 4th one. Again, I want to go as towards the tendon as possible so that we have all 4. Okay, so now when I am going to just push it behind. So this is what is going to happen eventually. Yeah?
Yeah. Right.
Okay. So this is what we are looking at. So this is what we have begun with. Okay. Now you can see that anteriorly there is hardly any labrum. So this is more like a ellipsa lesion. Some might argue that this is not the best case for doing a arthroscopic Bankart repair. Okay.
So how many episodes this fellow has?
He's got about 4 or 5 episodes.
Sir, is there any particular rotation of the arm you keep while tying the Remplissage stitch? Is a neutral rotation or slight external rotation? Or
no, actually I keep it in neutral only. I have not found that it causes any degree of internal rotational restriction in any of the patients. Most of these patients are essentially quite lax to begin with, especially in the Indian population. So what I am doing is now I am going to erase all this. You can see that I've just started I've just started removing it. See, there is no labrum whatsoever. I intend getting this particular tissue up. Okay, so let me just release this. To me, this is probably the most important part of the surgery. You can use your scope in order to help you create a little space there. So that's what I'm doing. The entire anterior-inferior tissue has basically migrated inferiorly, as you can see.
Yes.
And that's how I'm able to raise that tissue up. Sorry?
It's beyond 6 o'clock. You will be going?
Yeah, I'll go to whatever I think. Let me just, I'm still close to 5:30.
Yeah.
It has a bony flake, probably this is the region of the bony flake here. Yeah. But
Dr. Avinash, please unmute yourself. Unmute.
Narvekar sir,
Yes, sir.
Abhinay, regarding timing of the Bankarts versus the Remplissage, are there some authors who believe in doing the Remplissage first? Is there any advantage?
no, I don't. You can never do the remplissage first.
So mainly the Bankarts first.
So your
followed by-
point, yes. But what you can do is what I have done. You take the sutures first,
Okay,
but tie the sutures at the end.
sure.
तो दूसरा देना शेवर बगिया. So you see this something which was absolutely not there when we started off. We've got a fairly good amount of tissue which with a little bit of elevation I think I should be able to get it up. This is not under tension, so somehow I'll have to use some sort of stitches and a different type of sequence. मला हे दे आरिफ. चालत नाही आरिफ. Just hold the cannula when I'm taking it out. आरिफ चालत नाही रे. दे हे दे पेरिओस्टियम दे. पेरिओस्टियम दे शेवर देतोयस मला तू.
Is there any glenoid bone loss on this in pre-op assessment?
Take out. Yes, there is a 15% glenoid bone loss.
Sir, what is the significant glenoid bone loss where you decide not to do the reconstruction?
I think as we all know, this is the stage of critical bone loss, 15 to 18%. So if he's a young guy with, has got an anticipated higher level of activity, etc., then you know that this particular guy would probably be benefited with a Latage rather than an arthroscopic Bankart. The chances of failure are higher. But somehow I think as far as our Indian population is concerned, I would still take about 20%.
Hmm.
Okay, because I think our techniques of doing this also have improved.
Okay.
Okay, you can see that if I just release that, you know how much I'll be able to get.
Hmm.
And yeah,
The IGHL part of it,
yeah, this is,
capsule posterior and the
so if I'm able to go here, then I'm going to release this.
how close is the axillary nerve, sir, in this
It
tape?
should be much distal, no? I'm touching the bone.
Okay.
So once you are with the bone, then there is no problem. So here you have to be along the bone. Don't get away from the bone. Yeah. So I think now we have a fairly good mobilization. Yeah.
Yes, yes.
All the way. I can take a, just hold this. All that I have to do is come a little bit more in this area. And you can see how there is hardly any tissue over here.
Yeah. Quite flimsy.
That's what. So, but I'm not bothered too much because this is almost at 3 o'clock. Just pakad. I strong there. So this is what we want eventually. Yeah?
Yes.
A little bit more release out here. But this is the tension that you want in front.
Okay.
Periosteum. And then cure it. So first, still I need to release a bit. That is what I plan to do. Everything is flimsy beyond this, so don't intend doing anything more there. I just take it down from here. Give me the ice stone, please. And therefore I get this. Okay?
Yes.
Nicely mobilized.
So now our first anchor would be somewhere here, correct?
Yes.
You don't want to be absolutely at 6 o'clock with the anchor because then you have no tension on the tissue.
Correct.
So let me take out the cartilage. Oh, Q fix.
So is it mandatory to take off this all the time?
It is mandatory to take this out, otherwise you can't have healing on articular cartilage.
So how much how much medial you can go on this? Just on the face of the glenoid?
Yes,
So already
absolutely.
there's 15% loss.
Yes. On the face of the glenoid. Because if you put it on the edge of the glenoid, it is not going to heal.
But that doesn't shrink the volume further.
No, because the glenoid is the same, you are removing the articular cartilage. You are not removing the glenoid.
Yeah, only the subchondral part is exposed.
Yes. So the cartilages of what you are removing, the glenoid is still there. You are not removing bone. Sure. One hour, na? Sorry? We have an hour, right? Okay, I think we should be okay within an hour. Most of it, if not all. चल मला दुसरा शेवर घे हे सगळं ब्लॉक आहे आणि मला घासायला दे क्युरेट पण दे रे क्युरेट दे 1 मिनिट आणि घासायला पण दे So this is the other instrument I use because you want everything to heal. That you can't have soft tissue on it and expect the soft tissue to heal on soft tissue. So I spend a lot of time in doing this.
So how much the loss of rotations with this Remplissage?
Sorry?
Loss of rotation with the Remplissage?
What is the question? Loss of rotation.
The rotation of the
With
shoulder.
Remplissage, I don't think we have much of loss of rotation. And if there is a loss of external rotation anteriorly because of what I am doing, I don't mind.
Yeah, but not because of Remplissage. There is
No.
not going to be any internal rotation, external rotation there.
मला एक हे दे अँकर टाकूया आधी हे बघ बघूया अरे दे काय रे संजय घेऊन ठेवा ना So see there are two ways that you can take this first stitch. Either you can take it with the scorpion, okay, or you can take it from behind to forward. Give me the Acupass right. भरलं का? And eye strong दे. Eye strong. Hold the camera. जरा ते दे.
So eye strong is pulling it up and you are taking it from posterior.
Yeah. Okay, so I can get this bite here.
Right, right.
Otherwise, it's difficult to get the bite from the same side. Yeah, this is what will
Yes.
happen. Yeah. Okay. Here. Sir, 1 minute. मला एक अँकर दे कर्व सो हे जुनं घेतलंय रे काय हे त्यांनी जुनं दिलंय सो वी वॉन्ट टू गो हिअर
Yes.
Okay, धर 1 मिनिट I want to change my grip so that she can work.
All going to be suture anchors.
Yeah, I'm just putting the first anchor. Hook. Okay.
Is that a 4.5 mm, sir?
So this is a all suture Q-fix,
Yeah, okay.
curved anchor.
Okay. The flexible, it goes posterior. Curved anchor in the sense?
Yeah. I'll just show you. ठीक है, ठीक है, ठीक है. इधर ते दाखवायचं त्याला. Okay, that's where we wanted our first anchor.
Yeah.
Okay, can you show from outside? This is what we mean by the curved. This is the curve. Can you see that?
Yeah.
Yes.
Okay,
yes.
so this is the curved Q-fix. It has got a sort of a line here, and it shows there are two lines. One
Yes,
of them
correct.
is got away, but this is the curve which tells you which side the curve is, the convexity. Because once you put in, you do not know where it is, right?
Correct, correct.
So this convexity, I mean, this curve tells you which side it is facing, and this tells you where it is aligned. So, sorry, so there are two lines here. 1 minute. So there are two lines, one is a straight line and the other is a curved line.
Right.
And that is how this is a curved anchor. So you can go up to 5 o'clock and not go through the
Yeah,
inferior
it can
portion.
penetrate better still
Correct.
in the bone.
Correct.
Always.
And as a matter of fact, it is all suture, so there is no problem.
Yeah, but this is the flower is how much, sir?
Sorry?
When you pull the sutures out, I mean, when you tighten up and lock the anchor, what is the flower size inside?
What is the flower size?
Yeah,
4.5.
yeah.
That's what.
And the drill is 1.9.
Yes, 1.8 I think.
1.9.
I strong there. Okay, so now we've got the inferior anchor in.
Yeah.
Sir, next. No, no, मला ह्याचा नॉटलेस. I strong दे, हे दे मला. I'll take the knotless very close to the first one. This is where our first anchor is. So I will go to the next anchor will be here. The next anchor I'm putting is a knotless fiber tack,
Okay.
which is going to be fairly close to the anchor that we have put. Cut. Hammer. Okay. Bas. Drill. Yes. Okay. So this is a peak anchor. It's a knotless anchor. And the reason for using a knotless, I'll tell you later. Bas. Cut. So as you can see, this has got 3 threads. So what we are going to do is first pass hither. This is the thread that would, or a suture that will go through the tissue.
Yes.
नको हे. मला accurate. This is what we will do now. Pass it. घ्यावं लागेल. नवीन आहे.
नवीन आहे नवीन.
है हां तर वेळ आहे अजून. तर
ते वेगळे ठेव बारीक आहे.
always ask your assistant to push the hand down so this comes up, then you can take it out easily. Okay, very good. So we'll first pass this. नाही, तुटलंय काय?
तुटलं आहे.
हां
लूप तिथे आहे.
असं लूप तिथे कसं गेलं? हां हिरो लोक उलटं लूप घातलं काय? हां
तुम्हाला दुसरं देतो दुसरं.
काय थांब हे काप आणि एक ठेव परत म्हणजे काय हे काप ना एक राहील ना. सिस्टर उल्टा नहीं डालना लूप. चल के ठीक है नाउ दे मला आधी आय स्ट्रॉंग दे. Now whenever you do not have a loop like over here, it's always better to make one internal or a virtual cannula. Okay? So when I say virtual cannula, what I mean is the other two threads are to be pulled, please. Yeah. This is to be pulled. Where is the thread gone? हे जरा डोळ्यावरचा लाईट काढ मला दिसत नाही आतमध्ये. हां ओके राईट. सो we don't want that, sir. We want these two, so that there is no confusion in terms of, right, these two. They have to go in one particular track. If you don't do that, then they will take another suture with them and it will be a disaster.
Yeah.
You are with me or?
Yes, yes, sir.
Yeah, we are completely with you.
Okay, so now what has happened is, as you can see here, we'll just give me an ice tong. I just need to remove this. Remove that from underneath. जरा curved आहे काय?
Yes.
One sec, don't touch. Okay, so again, what we've done is, बरोबर ना दोन ह्याचे दोन इथे कुठे
हे पहिल्या याचे पहिल्या अँकरचे.
हां आणि हा इथे आहे ना हां सॉरी करेक्ट ओके ग्रेट. So now what we do next is that she is going to just pull only the loop one. Yeah. Is this the looped one? So I'm taking the looped one and these two.
लूप
तू
सोडा
काय करतेस ग? तू धरू नको.
लूप सोडा
नाही तिने चुकीचं यार, तिने काय केलं मला माहित नाही. सोपी गोष्ट नाही करू शकत यार तुम्ही लोक. काय ग? You know what you have to do? You have to just pull quickly and leave it. दोन्ही कशाला खेचते? You want to identify, no? हे हा खेच, हे धर. काय यार सच्ची. Just can you just pull quickly the loop, otherwise I'll pull it. Thank you. Okay, so don't pull the other one. So you know this is the looped one.
सोडा लूप सोडा
तू काही करू नको, लूप धरू नकोस. हे धर. काय यार. काय करते बाई यार. आणि लूप वाला कुठे
इथे
आहे?
इथे खेचावं
हं?
खेचावं लागेल हे दोन आहेत ना खेचावं लागेल
Okay. So what we have, पकड़, हे बाहेरचं दाखव. So we have this portion which has gone through the tissue. This portion is the loop.
बाहर से थोड़ा magnified, should be magnified.
बाहेरचं magnify कर. So we are putting, so now this loop has gone through the anchor. Now we are going to take the suture which has gone through the tissue to go through the anchor in the form of a loop.
Yes.
So I am going to pull, and as I pull, you can see that I give a little tug, yeah,
Yes.
and then my anchor has gone, I mean my suture has gone through the loop, okay?
Yes. Yes.
So now when I pull,
Inside.
can you see that tissue and can you see the loop?
Yes.
Great. So what is going to happen is that when I pull this, जरा हाथ ऊंचा. I just want to keep it like this. I don't want to pull it now. I'm going to pull it later. So when I pull this, it's going to pull that tissue under tension. Okay? So that
Yes.
is the loop which I have created and I have kept.
Okay.
Can you see that?
Yes. Yes. Yes.
So that is how the loop is going to pull that tissue. But I don't want to do that now. I will do it after the next anchor.
Third anchor. Okay.
So this is what I'm going to take out. And then I'm going to put the third anchor. And where am I going to put the third anchor? That will be even more proximal. I'm just trying to take the entire this tissue, which is meaningful tissue, as much in up as possible. So if my third anchor is somewhere over here, correct? I'll get a nice good tension on this entire tissue. So my third anchor is going to be here. There.
Okay.
Again, it is going to be a same anchor. It's going to be a knotless suture fiber tack.
Okay.
This morning we used a knotless anchor for doing the IT band tenodesis. Cut. Hammer. Okay. Drill.
It was the same anchor, sir. It was the same anchor.
Same anchor. Because you want tension.
Do you find any difference in execution in different anchors? Any particular
Yes.
thing? Like
I'll
when
just
it-
show you, Hital, I'll just show you what happens when you are using this anchor.
Okay. Okay. Perfect.
So,
This is a knotless anchor.
this is a knotless anchor because you can really give tension in the direction of the pull. I'll show you what I mean. Okay, thank you. You just take this out.
The peak anchor, no, sir? The peak anchor.
This is a peak anchor. You also get all suture anchor.
All suture. Like the one in the morning.
Yes. Okay, so we repeat the same steps. Take this away. I will get
The loop is in the,
anchor. Right now the loop,
this thread is different. This is to go
this
through
is
the
to go through the
stitch.
tissue.
To the
You're right.
tissue.
Correct.
And this has the loop.
मला एक आय स्ट्रॉंग दे पाठवून. Yes. Let me see if I can pull this a bit. What's इधर जरा. Okay. Being a little greedy, taking too much. Let me see if I am able to. Just forget it. Pagad. Again, you want to create an internal or a virtual cannula for this too.
Yes.
अरे यार इसका थ्रू. Give me the. I don't want it inside it. I want to. Yeah. So that no. Okay. Right. So this becomes a cannula. So these two only will come. Yeah. Because we are all sutures are only through one cannula.
Okay.
All my sutures are through one cannula. I tie this. This will come out separately. So I have got this tissue now. Yeah.
Yes.
We now do the same thing here. Right? Acha, बारीक वाला loop है. That's what he is saying. Okay. So what we do is we take बारीक वाला and we take this. So we don't have to do the other step of knowing which one is which.
Okay. Okay, so we've got the loop and the thread through which it has to go. Are you able to see from outside or no? No, not clear, very clear.
Not clear? Can you just hold it? तुम्ही तिकडे
That,
गेला
that should be, yes.
जरा हाथ से करके लो ना, इधर लगा के रखेगा तो.
Correct. So that tissue thread is going through the loop.
Correct. The tissue thread is going through the loop.
Yeah.
Okay, and now
Yes.
I'm going to pull this way.
Inside view, please.
So now this goes through the anchor
Yes.
and the tissue.
When it goes through the ankle,
Can you
you
leave
need to
this?
give a jerk.
Yes. Okay.
Yeah.
Right. Now what I want to do is I want to show you what the use of this anchor is. And the basic use of this anchor is that you want this tissue to be pulled while the anchor or the thread tensions it.
Okay.
So this is under tension and this is what it does.
Okay. Yeah. Okay.
See that?
Yes.
Every other, if you were to use a knot, you would push the tissue
Yes.
to the anchor. This will pull the tissue to the anchor. And this is exactly what you want. Correct?
Correct.
And now the last part is that if you want any further tension, you will get that further tension when you use this combination cutter cum tensioner. So what it does is that it goes in here, it's on the anchor there, so the anchor is not going to get pulled out, and I can give further tension on this, and cut it. Okay?
How is lock inside, sir?
Pakad. Now you see that the head has come centered. Only one particular
Yes,
good stitch
yes.
and the head is centered. Now we'll go to the central one and then we'll go to the last one. Okay?
The loop will lock it, basically. Loop locks it inside.
Yeah, it is going through the tissue and through the anchor.
Yes.
Now we'll take this. We already have the loop of that into the tissue.
Right.
Correct? So I can just,
It will be
I have to
from
pull
the
it.
anterior port.
so all that I have to do now is pull this, see that? There, and it pulls the tissue right into the anchor. Okay?
Yes.
And I do further. So this is the whatever, cutter cum pusher,
Tensioner.
tensioner. So it has got a mouth which goes nicely into the anchor. So I can push it, get a further tension on it, cut it. Next is the last one. So my sequence of actually suturing or tying, suturing is one but tying is another. So my sequence is entirely different. So what you do is you just do this, so I can get that. जरा सा हाथ उचलायला लागेल. सोड.
सोडले.
Okay. Now you want to just check which one is which. Just hold this, please. So I want to check which one is which. So this is through the anchor, this is through the tissue. Okay?
Black loop will take the one near
The most
sphenoid.
inferior tissue up. And then if we want, we can put another anchor on top, or then we can call it a day and just stitch.
Remplissage.
Thoda sa, not much. Thoda bas. Lovely. So this is the only one that I use as a knotting
Or
anchor.
suture.
Yeah, this suture where I put a knot. Good. दिसत नाही हात काढ दिसत नाही रे तू उलटा येतोय हे धर इथे Let's cut this suture. Lovely. Okay, so now from nothing we've got all this. I can now just simply take that small tissue. As I said, I'm interested more in 3 o'clock.
Yes.
Okay, eye strong. Now we'll take a simple anchor for this. You don't want to take any fancy anchor for this. And just get this and put this up. Okay.
Yes.
So this is just for cosmesis more than anything else. Chal ge.
Sir,
Puts up on.
just a question. With
Sure.
so many anchors available in the market, can you give us some education as to how do you handle different anchors? Which ones do you prefer in what conditions?
See,
But-
wherever I have to give this type of
Think to
tension, no,
people-
where there is no tissue, this tissue is created from the alapsa lesion. So you saw that most of the tissue is collected inferiorly. That tissue you wanted to pull up and get it in front. Therefore, you first want to have a tension on this anchor, correct? Proximal anchor.
Correct.
If you have to do that, then probably you use this type of knotless anchor.
Correct.
The other anchors that you use, suppose if in case the person is more acute, has had only 1 or 2 dislocations, all the labrum is nice and good, you don't really have to give too much of superior traction onto it, then
Correct.
those you can use probably the cheaper one, which is the all suture. My only reservation of using all sutures are that if you have to do a revision, then there are big bogdas which are created by them.
Correct.
You know, so that is the only issue as far as the all suture is concerned. Cost-wise, of course, they are cost-wise they are quite cheap as compared to any other.
Correct.
All sutures cause a lot of osteolysis, sir.
Sorry,
They cause osteolysis or just the
no, because you know it forms a big bogda, na?
granuloma? Oh,
Because, huh, Mar?
4.5 it is.
Yeah, okay. Because it will make a big hole, no? 4.5 millimeter
Yeah.
of no bone underneath the subchondral bone. Oh. So that way peak might be a better idea. Cut.
You
Because
can drill through it. You can drill through it.
yeah,
if
you
it
can
is a
drill through
revision.
it.
Yeah.
But I think if a Bankart fails, then essentially you are not going to do a Bankart again.
Correct.
You are going to do a Letarge or something.
Yes.
Correct.
So there it really probably wouldn't matter much.
Yeah.
So here we are using an all suture anchor from Smith Nephew. The first one also we used was from Smith Nephew.
But that was a curved one.
That's a curved one. Okay, this is not a curved one. This is a straight one.
Straight. Okay.
So it's called a suture fix, which is that is known as a Q fix. Yeah, so many anchors and so many names.
Absolutely. That is the reason, because someone who is just beginning the practice, they will get confused as to what to use and what not to use.
So this is the standard way that we probably were using our anchors first, that you take out one suture, put it into the other cannula so that you have no confusion. So it goes from anterior to posterior, and then you basically take the stitch. See that you don't see here some people also take the subscap, so you can take the stitch off the subscap, not just the middle glenohumeral. You take the subscap and you put the anchor over here, so you have the subscap also acting as a sort of a restraint anteriorly. Subscap tendon, upper portion.
It doesn't cause any.
No, I have done it couple of times where there is absolutely no tissue, and I mean I don't think we've had any problem with that patient in terms of restriction of movement or something. So here there is not much to save. I mean there is only 2 threads inside. So I think if you were to look at your anchor when you are pulling the threads, then you will not create a problem. I think what the new person would probably have a problem with is essentially a lot of suture management. You will discharge some anchors because you are pulling the wrong end of the suture, etc. But if you were to look at the movement of the suture at the anchor rather than outside, then I think you would not make that mistake.
Correct.
Can you show me please? ह्याचं चालू झालं नागराची केस चालू झाली चालू हो गया ना चलो हो गया अभी मेरा हो गया Great, so we have a good repair there, the head is back, totally centralized, okay?
Yeah.
So now what we need to do is basically take this off, okay, we remove this and then we will just tie these, okay, so that, see if you were to do the Remplissage first, then the whole thing when we are doing anteriorly is going to push
Yes.
and therefore it would obviously fail. So just look at this here.
Yeah.
We are going to first tie the more inferior one. Oops. So this is an uncomplicated way of doing a Remplissage. You don't go into the subacromial space and do all the bursectomy there and then see etc. हाड हे करायचं आहे पुढून
मॅडम हे केलं पुश केलं
अशी काय पुश करते जरा व्यवस्थित पुश कर ओके या बट आय एम थ्रू विथ दिस या सो आय एम ऑल्सो गुड हिअर ग्रेट
So which is the cutoff point for lethargy, anterior bone block surgery? Will this Remplissage with anterior soft tissue repair compensate for a patient who might need a lethargy?
But might need me, we've got to make that decision at least
No, but when would
when
you,
it's going to be pre-operative, no?
Yeah, no. In pre-op only. So how do you decide whether it's
So we decide on the
Remplissage
degree of bone loss
only? That is the only criteria.
primarily. Then what is his projected level of activity, the number of dislocations that he's had, whether he's had any night dislocations or no. Okay, what is the age of the patient? So all these would contribute towards your decision, and obviously in revisions.
Yes, revision is.
Besides the quantum of bone loss.
And when do you decide bone grafting of this big insects?
Hill sacks, I don't do any.
So if it is a large hill sacs, you are happy doing the Remplissage.
Remplissage, yeah. I have not done any bone grafting of hill sacks. I mean, as you go on doing newer
So
things,
how far, even if it's a big bone loss, in the sense bone loss.
people have been doing Remplissage with Letarge, but
Yeah.
I think once you do a Letarge, then you are circumventing this problem completely, no? So that's our Remplissage, right? Look at the
Yes.
tissue very nicely gone into the humerus.
Yes, yes.
The head is behind. See that? And the whole tissue is there.
Yes.
So that's our Remplissage with. Okay, nicely centralized head.
Yeah, perfect.
Okay.
Perfect.
Thank you,
Right,
sir.
sir.
Textbook,
Thank you.
textbook pictures. Thank you.
Thank you.